Good morning to all. I welcome Honorable Emeritus Chairperson Sir, Dr. Swarnka Sir, Dr. Achal Gulati Sir, Vice Chancellor of Mahatma Gandhi Medical College, University, Dr. V.K. Kapoor Sir, Dr. N.D. Soni Sir, Dr. Malhotra Sir, Dr. Jaiswal Sir, our Director, Dr. Sachdeva Sir. Today's combined clinical round is in nuclear medicine. So I welcome to all. Our Department of Nuclear Medicine has started on 2019 with a one PET-CT machine and dual head gamma camera for imaging purposes. Then we have started in 2021 MD course with 2 seats every year. At present, we have 6 MD students and 1 MSc Nuclear Medicine Technology student also. In 2022, MSc Nuclear Medicine course was started along with the high dose radiation therapy ward in hematology tower. In 2024, in-house 68 germanium, 68 gallium generator also started along with the installation of the second PET-CT machine in hematology tower. In the Department of Nuclear Medicine, I am Dr. Karan Singh Pipre, Head of the Department of Nuclear Medicine, and we have Dr. Ram Singh Meena, Dr. Himanshu Panchal, and Dr. Kaur in the nuclear medicine as नहीं सर अभी नहीं होगी but it is I think in process. And newly joined one assistant professor in radiation safety division and nuclear medicine technologist. We have 6 postgraduate students of MD course and 3 radiation safety officer, level 3, level 2, and again assistant professor and level 3 radiation safety officer, which is a great achievement of nuclear medicine department. This is PET-CT camera in Sri Ram Cancer Center along with my staff, PG, radiation safety officer and MSc candidate and nursing officer. We are giving or providing all type of the nuclear medicine services in our department, including technician 99M, labeled radiopharmaceuticals, FDG, PSMA, gallium radiopharmaceutical, all type of the investigations we are giving to the public. These are 2 PET-CT machines. One is in nuclear medicine, old machine in Sri Ram Cancer Hospital and newly installed in hematology tower. And this new machine is also performing 15 to 18 PET-CT cancer patient investigations and PSMA gallium also in hematology tower. So it is again increase the number and total PET-CT number, it is coming sir, all the data. This is dual head gamma camera, SPECT, along with the gallium generator on the left side, my left side, right side. This is gallium generator and molybdenum generator and high dose radiation therapy ward for the treatment of follicular cancer and papillary thyroid cancers. We have 4 wards of the patients, separate patients. This is gallium generator and molybdenum generator and high dose radiation therapy ward for the treatment of follicular cancer and papillary thyroid cancers. We have 4 wards for the patients, separate patient. These are the statistics of our department. From 2019 to 2023, we performed 15,000 50 patients of FDG PET-CT of various cancer, and in 2024 till date 1655, and average is about 28 to 30 patient in both the machine per day. Number is just double in last month. We are also diagnosing prostate cancer with gallium PSMA till date in 24 35, and in 19 to 23 291, and with gamma camera dual head in this year 173 and 1055 from 19 to 23, and therapy also active iodine 131 in 2019 to 2023, total 134 and 47 in 2024. Lutetium dotatate also used, total 22 patient. Lutetium 177 PSMA for prostate is 5 in this year and 6 it was in last years. And bone pain palliation also in cancer patient, metastatic disease, bone pain palliation with lutetium EDTMP. 1 in this, it is very rare patients are coming in our department for bone pain palliation. We have organized 4 national CME conferences and seminars in our institute. The Department of Nuclear Medicine will present the combined clinical round case. I will invite to Dr. Gurdas Singh.
Good morning, respected teachers and my dear colleagues. Today we'll start the clinical combined round. A 26-year-old female with abdominal pain, along with the Department of Medical Oncology, Department of Oncopathology, Endocrinology and Radiation Oncology. So, to start with the case, I invite Dr. Chavi Goyal, DM second year resident from the Department of Medical Oncology.
A very good morning to all the respected teachers, seniors, colleagues and juniors. I am Dr. Chavi Goyal, a second year DM Medical Oncology resident, and I will be presenting today's CCR. So, a 26-year-old lady, homemaker, married with 2 children, presented with abdominal pain for 3 months. The pain was insidious in onset, diffuse, mild dull aching, associated with generalized weakness, non-radiating, partially relieved on taking medication, which she required once to two times per week, with no aggravating or other relieving factors, no association with food intake, no history of abdominal distension, vomiting or loose stools. There was no history of any fever, loss of appetite or weight loss, no history of any abdominal mass, and no history suggestive of jaundice. In past history, she had no significant past medical or surgical history. She is a vegetarian with normal appetite, adequate sleep, normal bowel and bladder movements, and no history of any addictions. Her family history is non-contributory. In gynecological history, she attained menarche at 14 years of age and has a normal menstrual cycle of 35 days with 4 days of bleeding phase. Her last menstrual period was 12 days back from date of presentation, and there is no history of any foul-smelling discharge per vaginally. She is a mother of 2 with full-term normal vaginal deliveries, and last delivery was done at the age of 22. Since the history didn't tell us much, so we further proceeded to the general physical examination of the patient, and she was conscious, well-oriented with a BMI of 20 kg per meter square, comfortable with vitals under normal range with a blood pressure of 126 by 84 millimeters of mercury, pulse rate of 86 per minute, 12 per minute respiratory rate, and 98% saturation on room air, and she was afebrile, and with mild pallor, no icterus, no palpable lymph nodes, no clubbing, cyanosis or pedal edema was seen. On abdominal examination, on inspection, the abdomen was scaphoid with inverted umbilicus, no scars, no dilated veins. On palpation, it was soft, non-tender, no guarding or rigidity, no organomegaly or any palpable mass. On percussion, the abdomen is tympanic with no evidence of free fluid, and the liver span is 11 centimeters at mid-clavicular line. On auscultation, there was normal bowel sounds present and no bruit heard. Her rest of the systemic examination was within normal limits, including the perrectal and pervaginal examination. To summarize, she is a 26-year-old lady with 2 children with dull aching, diffuse abdominal pain and generalized weakness since 3 months. Her vitals, her general abdominal and other systemic examination was within normal limits. So since abdomen is a Pandora's box, and at this point there could be a lot of possibilities from gastrointestinal to hepatopancreatobiliary, genitourinary, neuropsychiatric, it could be functional and others. So we further evaluated and investigated the patient to get more hints. So a workup was done in which she was found to have mild microcytic hypochromic anemia with a raised ESR of 36 mm per hour, raised SGOT, SGPT 76 and 80 units per liter, a raised alkaline phosphatase 284 units per liter, and a slightly raised serum bilirubin with a total bilirubin of 1.8 milligram per deciliter. Her stool routine examination revealed no occult blood or ova or cyst. Now at this point I would like to ask the audience what should be the next investigation with above history and findings. Anybody? In abdomen with a 26-year-old female with abdominal pain, what could be the next investigation? Yeah, so it is ultrasound, and ultrasound whole abdomen was done, which revealed well-defined hypoechoic mass in left renal hilar region measuring 33 into 32 mm, and it was suspected to be a lymph nodal mass. So with this finding, she was also advised a CCT whole abdomen, which was suggestive of multiple peripherally enhancing necrotic lymph nodes in peripancreatic region, para-aortic and aortocaval region, largest measuring 28 into 27 mm at left renal hilum. Large lymph node posterior to pancreatic head causing compression of distal and mid CBD was measuring approximately 3 centimeters. An lytic lesion at the right 8th rib with associated soft tissue component was also seen. So to summarize again, a 26-year-old lady with 2 children with diffuse dull aching abdominal pain for 3 months, normal vitals and examination, and on investigation found to have mild anemia with raised ESR and slightly deranged LFTs, and multiple abdominal lymph nodes with a solitary osteolytic lesion in the right 8th rib radiologically. So what could be the differentials, if anybody? We examined the patient and she was minimally symptomatic with no other finding. So at this point the differentials could be infectious causes, non-infectious causes and malignancies. Infections could be any chronic infection like bacterial, tuberculosis, it could be viral, it could be fungal, or it could be any parasitic infection. Non-infectious causes could include sarcoidosis, autoimmune causes, serum sickness, Castleman disease, or any drug-induced cause. In malignancies, it could be a lymphoma, sarcoma, or carcinoma. So now, what could be the next step, if I may ask? So obtaining a tissue diagnosis at this point is very important for us. So a patient was subjected to a USG-guided FNAC from para-aortic lymph node, which revealed necrotic granulomatous material. A USG-guided repeat FNAC from rib lesion, which was inadequate for opinion, and a repeat USG-guided FNAC from parapancreatic lymph node, which revealed scattered cells having abundant cytoplasm with round oval nuclei and vesicular chromatin, suspected malignant neoplasm. So now with an inconclusive diagnosis and a suspicion of malignancy, the patient was further advised a whole body PET CT scan and a biopsy. A whole body PET CT scan was ordered before because patient was already subjected to invasive needling 3 times, which revealed nothing. So we ordered a PET CT beforehand to look for further characterization of disease, extent of disease, and to guide appropriate biopsy site. So now I would like to invite Dr. Gurdas Singh from Nuclear Medicine to discuss the PET CT findings.
Good morning, respected sir. So the patient came to us to the Department of Nuclear Medicine. So the patient came for 18F FDG whole body PET CT scan, and as we can see, these are the representative whole body coronal images. This is the whole body PET MIP image, which can see multiple focal tracer uptakes at the various part of the thorax and abdominal regions, along with the physiological FDG uptake in the brain and myocardium, along with the urinary activity. Then we can see the whole body CCT images and the coronal sections of the whole body fused PET CT images, along with the increased focal tracer uptake at the right 8th rib region and the left proximal humerus, and various focal increased FDG uptake at the abdominal and retroperitoneal regions, along with the pelvic regions. So these are the few representative axial fused PET CT images, which shows multiple focal tracer uptake at the mediastinal lymph nodes, left axillary lymph nodes, and retroperitoneal lesions and mesenteric regions, with SUV max at the right 8th rib lesion, as we can see here, of 32.07, with lytic lesion and soft tissue component, and the retroperitoneal lymph node along the periportal region with 21.8 and measuring approximately 3.3 into 1.8 centimeters. So with the above findings, we gave the impression of FDG with multiple lymph node and lymph nodal masses in the cervical, supraclavicular, bilateral axillary mediastinal, abdominal, retroperitoneal and mesenteric regions, and FDG with multiple lytic lesions at the left humerus, few bilateral ribs, sacrum, right iliac bone, and few of them showing soft tissue component. So with these findings, we had the differential diagnosis of either infective, they might be tuberculosis, histoplasmosis, non-infective, the sarcoidosis, and neoplastic lymphoproliferative etiology and metastatic disease with unknown primary. So with this, USG guided retroperitoneal lymph node biopsy was advised, and it was done.
So the patient underwent the response evaluation with 18F FDG PET CT scan. As we can see in these whole body PET MIP images, there is significant reduction in the focal FDG uptake. Also, in the coronal fused PET CT sections, there was decrease in the SUV max of the overall lesions. These were also the representative fused axial sections which showed decrease in the SUV max. For example, like in the retroperitoneal region, it reduced from 21.8 to 17.4. And post 4 cycles of the therapy, we gave the partial response to the treatment on the basis of PERSIST criteria, which said more than 30% decrease in the SUV max of the previously seen lesions. So, after giving the partial response, now I would like to call back upon Dr. Chavi for further notes.
In view of clinical and radiological response, she was continued octreotide LAR along with zoledronic acid every 4 weekly, and she tolerated the treatment well with minimal adverse events. After around 1 year of treatment, in March 2023, the patient presented with complaint of headache, palpitations, anxiety and generalized weakness since past 5 days. On examination, she had a blood pressure of 190 by 110 millimeters of mercury, and she was suspected to have clinical progression along with hypertensive urgency and was admitted for workup and management. Persistent hypertension was documented. She was evaluated for common causes of young hypertension, and Department of Endocrinology reference was taken after ruling out the common causes. So now I would like to call upon Dr. Puneet Shivnani from Department of Endocrinology to further take the case.
I am Dr. Puneet Shivnani, second year DM resident from the Department of Endocrinology. Assessment of endocrine causes of young onset of hypertension was done. On examination, her blood pressure was 210 by 130 millimeters of mercury. Her pulse rate was 130 beats per minute, and she had bilateral basal crepitations. So, in view of young onset of hypertension with a BP of 210 by 130 millimeters of mercury and features of left ventricular failure, and looking at the extensive disease and the PET scan, a diagnosis of pheochromocytoma or paraganglioma was clinically suspected. She was managed with IV NTG infusion and diuretics, and her alpha blockers were started, tablet prazosin 5 mg BD and tablet amlodipine 5 mg OD. So she was advised for plasma-free normetanephrines and serum chromogranin A levels, which were very high serum plasma free norepinephrines were more than 7200 and serum chromogranin A levels were more than 1100. So a diagnosis of extra-adrenal abdominal multicentric paraganglioma with multiple lymph node and bony metastasis was confirmed. Patient was counseled for genetic testing to look for hereditary or genetic causes of paraganglioma, considering the extensive disease at such younger age. The genetic counseling or the genetic screening was done in the form of next generation sequencing to look for the genetic mutations that cause paragangliomas. Her report turned out to be positive for SDHB mutations, which account for paragangliomas. So here is a table depicting various genetic mutations which are responsible for pheochromocytomas and paragangliomas. Our patient has SDHB mutation, which is responsible for familial paraganglioma type 4, in which paragangliomas are usually found in abdomen, pelvis or mediastinum. So a multidisciplinary team meeting took place comprising of Department of Endocrinology, Medical Oncology and Nuclear Medicine, in which a gallium DOTA-NOC PET CT was advised to assess the disease burden and suitability for targeted radionuclide therapy. So now I would like to invite Dr. Shubham Dadich from the Department of Nuclear Medicine to tell us further about the case.
Good morning all the respected dignitaries, faculty members and my dear colleagues. Patient was sent to the Department of Nuclear Medicine for DOTA-NOC PET CT scan, which was done on 27th of April 2024. The one on left is maximum intensity projection image, in which we can see the physiological tracer uptake in pituitary gland, liver, bilateral kidneys and spleen and urinary activity. The one in middle is CT scan, and the one on right is a fused PET CT scan, in which we can see there is a lytic lesion with soft tissue component in left proximal humerus with the SU max of 56.24. We can also see there is a right pulmonary nodule, right atrial lesion and para-aortic lymph nodes. On axial sections, we can also see that there is SU max of 56.24 in right proximal humerus. There is a pulmonary nodule with SU max of 23.97 and perihilar lymph node with the SU max of 15.23. So the final impression was SSTR expressing multiple lytic and lytic expansile bone lesions with soft tissue component, SSTR expressing multiple enlarged lymph nodes with cervical, supraclavicular, bilateral axillary, mediastinal, abdominal, retroperitoneal, mesenteric and pelvic regions, and SSTR expressing multiple soft tissue nodules in bilateral lung fields. And in Department of Nuclear Medicine, we generally compare the previous scan, we take history of the patients and we compare it with the previous scan. When we compared it, there was appearance of new lesion and increase in size of pre-existing lesions, which was suggestive of disease progression. So, after clinical and radiological disease progression, patient was discussed on first-line nucleotide therapy. The patient was discussed in multidisciplinary tumor board, and where the decision of second-line peptide receptor radionuclide therapy was taken, which was also according to NCCN guidelines. What is peptide receptor radionuclide therapy? As nuclear medicine is a theranostic branch, theranostic is combination of two words, therapeutic and diagnostic. We can use radionuclide to diagnose as well as to treat the patient. In this diagram, you can see that this is a cell membrane of neuroendocrine tumor with high SSTR, somatostatin receptor expression. Here DOTA is a linker which links linker peptide which links a vector to either a diagnostic moiety, which is a gallium-68, and this DOTA can further link our vector to either yttrium-90 or lutetium-90. So gallium-68 is a positron emitter and can be used for PET CT imaging, and this lutetium or yttrium-90 are having long half-life and emits beta radiation, can be used for the treatment of these neuroendocrine tumors, and this forms the basic of this PRRT therapy. And after intravenous infusion of lutetium dotatate, it gets concentrated on the neuroendocrine tumor cells due to overexpression of somatostatin receptors. They are further internalized and concentrated. They deliver radiation to the DNA and cause DNA strand breaks, leading to cell death. Indications in our patient were high SSTR expression, well-differentiated tumor with a Ki67 index of less than 3% and an inoperable disease. There were no as such contraindications in our patient. So, talking about lutetium, we receive it from BRIT, which is Board of Radiation Isotope and Technology, and this lutetium dotatate is produced in our nuclear reactors and transported into thick lead containers. And to be, as we can see in this photo, there is an expiry date on this lutetium dotatate. So we need to deliver this lutetium within 24 hours of production in Mumbai. And our center is the only center in Rajasthan which allows this. This is high dose therapy ward, in which pre-medication with antiemetics was done and continuous infusion of positively charged amino acids was given. After continuous infusion of positively charged amino acid, which helps in renal protection, 150 millicurie of lutetium dotatate was given by a slow IV infusion over 20 to 30 minutes on 4th of May 2023 under proper radiation safety precautions. And this is the post-therapy scan of the patient, which depicts that which was done on after 24 hours, which depicts that here we can see that in pre-therapy Dotanok PET CT and compare it with post-therapy scan, we can see nearly most of the lesions which were visualized on the pre-therapy scan are visualized on the post-therapy scan, which confirms that the drug has reached its target. Follow-up was done. A patient was discharged under stable condition and there was no adverse event related to the treatment. So follow-up was done with at 3, 6 and 9 weeks with CBC, LFT and RFT, based on which we planned our cycle in advance within 8 to 12 week intervals, and we planned 6 to 8 cycles in this patient. Second cycle was given on 20th of July 2023 and third cycle was given on 30th of Oct 2023. After 3 cycles in 8 months, we had good clinical response, and we did a gallium dotanol PET CT for follow-up, which revealed there was interval decrease in size at left proximal humeral lesion. There was significant reduction in left axillary lymph node size and SSTR uptake, and there was significant reduction of right atrial lesion, and there was the disappearance of right pulmonary nodule, which was suggestive of partial response to the therapy. But since the patient had pain in her left shoulder region and right pelvic region, the patient was sent to the Department of Radiotherapy for palliative radiotherapy. I would like to call Dr. Bhunesh sir to talk about radiotherapy.
Respected teacher, seniors and colleagues, myself Dr. Bhunesh Kumar Sharma, and with third year radiation oncology. Patient was sent to our department for pain palliative radiation to right atrial and left proximal humerus and right pelvic, right hemipelvis. All the 3 CTVs are drawn and 0.5 centimeter PDB margin are given. The total dose was 40 gray and 20 fraction to at the rate of 2 gray per fraction over 5 fraction per week over 4 weeks. Now I again invited Dr. Shubham for further continuation.
So after palliative radiotherapy to the left shoulder and pelvic bone, 4th cycle of PRRT therapy was given on 15th of Feb 2024. These are the post-therapy scan of every cycle, and we can see there is a successive decrease in size and tracer uptake in all the lesions, which is suggestive of good response to the therapy. Patient responded the treatment well, and there was no adverse event recorded during these cycles. So our goal was, with such a metastatic disease, was not to get a complete cure, but it was to get control the symptoms related to catecholamine excess, to improve the quality of life, which we have done from Karnofsky score 30 to 90. Or another goal was to improve progression-free survival and overall survival. and to reduce other complications, for example, pathological fractures, which we did with the help of palliative radiotherapy. All goals were optimally achieved. Now I would like to call our consultant, Dr. Himanshu Bansal sir, to further discuss review of literature.
Good morning, all the dignitaries, all the faculty members, and my dear colleagues. Myself, Dr. Himanshu Bansal from the Department of Nuclear Medicine. Pheochromocytoma, which originate from the adrenal medulla, and paraganglionoma, which originate from the paraspinal ganglions, are rare neuroendocrine tumors with worldwide incidence 6 cases per million persons per year. Metastatic disease is seen in 2 to 13 patients in pheochromocytoma and 2.4 to 50% cases in paraganglionoma. SDH mutations predispose 70% patients to the aggressive phenotype, resulting in metastasis, which was seen in our case. Malignant paraganglionoma can present with tumor-related pain due to large primary tumors or due to metastatic lesions, most often bone metastasis, which was seen on our case. 68 gallium proton of PET-CT scan and PRRT therapy have significantly improved the detection and management of neuroendocrine tumors. Objective response rate was seen in 60% cases in advanced metastatic neuroendocrine tumors with a progression-free survival more than 24 months. Lutetium-177 dotatate therapy was approved by European Medicine Agency in 2017 and US FDA in 2018. This was the landmark trial which led to approval of lutetium dotatate therapy, which was published in Journal of Clinical Oncology in January 2017. It was a phase 3 trial of lutetium dotatate for mid-gut neuroendocrine tumors, which shows death rate 80% lesser than octreotide group and progression-free survival 65.2% versus 10.8% at 20-month follow-up. Another study published in European Society of Medical Oncology showed disease control rate of 80%, and it also concluded that PRRT therapy is safe and effective therapy in metastatic paraganglionoma. This is an Indian study done in BARC Mumbai and published in Endocrine Connection in 2020. It is a lutetium dotatate therapy in metastatic inoperable pheochromocytoma or paraganglionoma. It also showed the similar result with a disease control rate of 80%, and it also concluded that it is safe and effective therapy in metastatic paraganglionoma. So, with the take-home message, neuroendocrine tumor poses significant diagnostic and therapeutic challenges. Nuclear medicine plays a crucial role in diagnosis as well as treatment of neuroendocrine tumors. A multidisciplinary approach is needed for adequate diagnosis and treatment. Genetic testing should be considered in a subset of paraganglionoma which are associated with familial syndromes. PRRT therapy with lutetium-177 as a new targeted therapy with good efficacy and safety profile. At the last, I would like to thank management of Mahatma Gandhi Institute to provide us all the state-of-the-art facilities in the Department of Nuclear Medicine and the CCR Review Committee for continuous guidance. We thank all the collaborating departments, Department of Medical Oncology, Department of Endocrinology, Department of Oncopathology, and Department of Radiotherapy with patient and family. Thank you so much.